Hello, good afternoon. This is Jasmine. So we are presented with a 90-year-old female Caucasian living in a skilled nursing facility who presented with complaints of intermittent productive cough of 2 days duration, accompanied by increased salivation, difficulty in breathing, sore throat, and chest pain when coughing. So breathing treatment afforded no relief. The patient is on Spiriva daily and on Flovent 1 puff BID and on continuous oxygen 2 liters. She had no fever or chills, no nausea or vomiting. So for the pertinent review of systems, the patient complained of generalized weakness. She has a poor visual acuity and hearing impairment. She has a sore throat, productive cough, and occasional wheezing, dyspnea, and on and off heartburn. She's incontinent of bowel and bladder. So the patient was diagnosed with chronic obstructive pulmonary disease at 70 years old or 20 years ago, and hypertension at age 65. She's now on lisinopril, 40 milligrams, and her blood pressure has been controlled. So she has abdominal hernia 5 years after her hysterectomy at 50 years old, and also diagnosed with gastroesophageal reflux disease, the same time with COPD or 20 years ago. There were no other hospitalizations except for surgeries of abdominal herniorrhaphy, hysterectomy, hemorrhoidectomy, cataract removal, and retinal surgery. She's allergic to sulfas and is lactose intolerant. Immunization, she's up to date with her flu vaccine. She has had her Prevnar 13 and Pneumovax 23. She has a strong family history of hypertension and lung cancer. The mother was hypertensive and died after a stroke. The father, lung cancer. So she has 3 siblings. One died, also hypertensive after a stroke. The other one, osteoarthritis, and the youngest apparently healthy. She has 7 children, 4 boys and 3 girls. One boy died of vehicular accident, the other of a brain tumor just a few months ago. So she started smoking at age 16, consuming 1 pack a day. She only stopped at 70 years old when she was diagnosed with chronic obstructive pulmonary disease and had to be on oxygen. So for the pertinent physical findings, vital signs was blood pressure of 110/70, heart rate 68, respiratory rate 28, temperature 36.8, O2 sat 96. Her height is 5'7", her weight is 167.5 with a BMI of 26.2. So we centered on the lungs and the abdomen. For the lungs, respiration was slightly labored with a respiratory rate of 28 and the use of accessory muscles. Was distant breath sounds, occasional wheezing, and fine rales at the bases. There was decrease in tactile and vocal fremitus and hyperresonant percussion. So for the abdomen on inspection, it was globularly enlarged with a surgical scar about 18 centimeters below the umbilicus. There was a prominent abdominal hernia and normal active bowel sounds, no tenderness. For the differentials, we strongly considered chronic obstructive pulmonary disease in acute exacerbation because of on and off productive cough, respiratory rate of 28 with the use of accessory muscles. There was wheezing and fine rales and decreased tactile and vocal fremitus and hyperresonant to percussion. We also thought of pneumonia because of productive cough, difficulty in breathing, although there was no fever and chills. So what we did was we ordered for chest x-ray which revealed no infiltrates, mild hyperexpansion, and parenchymal scarring suggestive of COPD, but the final diagnosis was no active disease. We also thought of angina because of chest pain. However, the chest pain would only occur when coughing, so it was more of pleuritic pain and non-cardiac. So our diagnosis is gastroesophageal reflux disease. What we did was we increased omeprazole 20 milligrams daily to BID, and we strongly advise the nurses to give it 1 hour before meals. And also we reiterated to the CNAs to put her to bed after 3 hours after meals, and to keep the head of the bed higher, like 45 degrees, and also to avoid coffee, which she takes regularly, and chocolates, which she loves very much. So there was a study done by ZED 2018, the Canadian Journal of Hospital Pharmacy, and also by Farrell et al. 2017, Family Physician Journal in Canada, that they are suggesting that we decrease this prescribing proton pump inhibitors, although proton pump inhibitors were said to be safe and effective compared to H2 blockers. They pose risk to elderly of fractures, pneumonia, intestinal infection like Clostridium difficile, and acute interstitial renal disease, also hypomagnesemia, and vitamin B12 deficiency. So the use of proton pump inhibitors must be closely watched for the elderly, for the prolonged use of proton pump inhibitors. Thank you, and I hope I need your suggestions and recommendations for this soap. Bye-bye.